بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. My topic today is about ovarian lesion with low T2 signal intensity. The differential diagnosis, common and less common differential diagnosis and rare causes, and the clues for the differential diagnosis with some examples. T2 signal intensity lesions with T2 signal intensity relative to pelvic muscle. Some lesions have T2 signal intensity iso-intense to the muscle, like endometrioma, like fibroma, fibrothecoma, cystadenofibroma, and Struma Ovarii. Some lesions have hypointense relative to the muscle in T2 weighted images, like Hemorrhagic Cyst, Krukenberg Tumor, and mucinous cystic neoplasm. We have lesion either solid, like fibroma, fibrothecoma, Krukenberg tumor, Adenofibroma, or cystic, Endometrioma, Hemorrhagic Cyst, or mucinous cystic neoplasm, or solid and cystic component. We have Cystadenofibroma and Struma Ovarii. Differential diagnosis. The common causes include endometrioma, hemorrhagic cyst, fibroma, and fibrothecoma. Clues for common diagnosis include endometrioma. On ultrasound, we have well-defined, smooth-walled uni or multilocular cysts, contain homogeneous low-level echoes characteristic of a ground glass appearance. Small echogenic foci occur in about 35% of endometrioma walls. Increased likelihood that cystic mass is endometrioma. A typical feature may be seen in 15% of cases. Mural irregularities usually are vascular, likely due to adherent mural clot or fibrin. Flow due to presence endometrial tissue. Malignant transformation to endometrioid or clear cell carcinoma can occur. In MRI, single or multiple uni or multilocular cyst, high signal intensity on T1 weighted images. Signal intensity remains high on fat Sat-T1 weighted images to differentiate from fat-containing mature cystic teratoma. T2 shading, signal loss in T2 in ovarian cysts that appear hyperintense on T1 weighted images. T2 dark spots, discrete, markedly hypointense foci within the cyst on T2 plus minus T2 shading. Here we have patient with a transvaginal ultrasound shows hypoechoic ovarian lesion with homogeneous low-level echoes and a small echogenic mural focus in keeping with endometrioma. Here, this is axial T2 weighted images, shows right ovarian lesion. The lesion is homogeneous, signal intensity similar to the pelvic muscle. And this is an endometrioma. This is the same patient with T1 weighted images with endometrioma, shows the mass high, shows high signal intensity. This is an example of T2 shading, signal loss in T2 in an ovarian cyst that hyperintense in T2, in T1 weighted images. This is another patient with axial T2 MRI, shows two endometriomas here, one, and this is another one associated with simple fluid in the pelvic cavity. And this is T2 dark spots, shows in the due within the left endometrioma. Hemorrhagic cyst, physiologic cyst only in a premenopausal woman, resolve in follow-up examination. Ultrasound different pattern may be seen: echogenic, avascular, homogeneous, heterogeneous, non-shadowing in early stage. In retracted clot, we have a vascular mass-like structure within an echoic cyst, has characteristic of concave contour, may gel with transducer ballotment. Reticular, lacy, fishnet or spongy pattern, irregular fiber lines that typically don't completely traverse the cyst. On MRI, usually single unilocular cyst, high signal in T1 weighted images, signal intensity remains high in T1 fat set, to differentiate from fat-containing mature cystic teratoma. Maybe hypointense on T2, more commonly hyperintense, no T2 shading, no T2 dark spots like in endometrioma. Here we have hemorrhagic cyst with the transvaginal ultrasound and Doppler examination shows that lesion is echogenic, heterogeneous, with no vascularity inside. Here, another patient with hemorrhagic cyst, the transvaginal Doppler ultrasound shows ovarian lesion with irregular fine lines, don't completely traverse the cyst. But this pattern described as co-web reticular lacy fishnet or spongy, and there is no vascularity inside. Here, this is a patient with hemorrhagic cyst, axial T2 weighted images. We have hyperintense in the periphery here and hypointense on in that area due to retracted clot pattern seen. And this is the T1 fat set, shows right ovarian cyst, hemorrhagic end-type with retracted clot in that area. Fibroma and Fibrothecoma. Fibroma can be associated with ascites and pleural effusion in a classic Meigs syndrome. Fibrothecoma may manifest with hyperesterationism estrogenism with endometrial polyp, hyperplasia, or carcinoma. On ultrasound, we have round, oval, or slightly lobulated tumor. Most are hypoechoic and solid with regular and slightly irregular internal echogenicity. Some contain cystic spaces. A dramatic sound attenuation resulting in posterior acoustic shadowing, minimal to moderate vascularization on color Doppler images. On MRI, T1 weighted images, hypo to iso-intense to pelvic muscle. T2 low signal intensity allows differentiating from other solid ovarian masses. T1 weighted image with contrast mild enhancement. Here we see axial T2 weighted images, left ovarian mass. It is low signal intensity, and this is Fibroma/Fibrothecoma. And this is the mass after contrast T1 weighted fat sat image with poor enhancement of left ovarian mass. Here another patient with axial T2 weighted images, large well-defined ovarian mass demonstrating homogeneously low signal intensity of Fibroma/Fibrothecoma. And this is the same patient with T1 weighted images seen as also well-defined large mass, homogeneously low signal intensity, less than the muscle. And this is the same patient also with demonstrating minimal enhancement of the Fibroma/Fibrothecoma on this T2 1 weighted images with contrast and fat set. This is on the same patient with ultrasound and shows that the large mass, it is echogenic, hypoechoic, well-defined hypoechoic ovarian mass with attenuation of sound posteriorly, resulting in posterior acoustic shadowing. Less common causes, we have a Krukenberg tumor, Adenofibroma, or Cystadenofibroma. Clues for less common diagnosis: Krukenberg tumor, non-primary tumor, commonly originated from the stomach in about 70% of cases, followed by breast, colon, and appendix, bilateral in 60 to 80% of patients. In MRI, we have heterogeneous solid and cystic masses with intratumoral cyst within the solid component. Variable hypointensity on T2 due to presence of metastatic mucin-filled signet ring cell in ovarian stroma and abundant collagen formation. Moderate to marked enhancement of solid component seen. Here we have this patient with axial T2 weighted images with history of gastric carcinoma, shows large heterogeneous mass lesion in the right ovary adnexia with a low signal intensity that's similar to the pelvic muscle. And this is a Krukenberg tumor. And this is the same patient. After contrast enhancement, T1 weighted images, fat sat shows heterogeneous enhancement of the mass lesion. Adenofibroma/Cystadenofibroma. On ultrasound, primarily solid adenofibromas resemble ovarian fibroma, or primarily cystic cystadenofibroma, predominantly cystic with irregular thick wall or septi, possibly more than 3 mm in 30 to 67% of cases. Solid component or papillary projection can be seen. On MRI, uni or multilocular cystic mass with solid fibrous component that demonstrate low signal intensity on T2 weighted images. Primarily, solid adenofibroma resemble an ovarian fibroma with a small foci of high signal cystic spaces. Primarily cystic Cystadenofibroma shows solid low-signal fibrous component may result in irregular wall or septal thickening, possibly more than 3 mm. Here this axial T2 weighted images left ovarian mass lesion will define low signal intensity with central high signal intensity noted. Due to this mass due to adenofibroma slash cystadenofibroma. And this is the T1 weighted images of fat sat after contrast also shows the mass well-defined solid mass demonstrated mild homogeneous enhancement. And this is cystadenofibroma with T2 weighted images which shows thick wall cyst. And it is low signal intensity of the cyst. This is the axial T1 weighted images after contrast and fat sat shows well-defined multilocular left ovarian mass with minimal enhancement. Rare but important causes, we have Brenner Tumor, Struma Ovarii, and Fibromatosis. Clues for the rare diagnosis, Brenner Tumor with ultrasound. Most Brenner tumors contain solid component, purely solid or uni or multilocular cystic with solid component. Cystic component is anechoic or of low echogenicity. Minimal flow on color Doppler ultrasound. Calcification in majority of cases seen, but it is best seen in the CT scan. On MRI, very low T2 signal intensity and low T1 signal intensity due to presence of fibrous elements plus minus calcification. Imaging findings overlap with those of fibrothecomas. Solid component demonstrating low signal intensity in mixed solid and cystic lesion. Typically demonstrate at least moderate enhancement after contrast material administration. Helps to differentiate Brenner tumor from Fibrothecoma, which are typically hypovascular. The presence of calcification and coexisting epithelial neoplasm favors the diagnosis of the Brenner tumor over Fibrothecoma. Here, with this transvaginal ultrasound shows large solid mass with foci of increased echogenicity due to calcification and marked attenuation of the sound waves resulting in posterior shadowing. This is axial T2 weighted images with large pelvic mass, homogeneous low signal intensity. It is difficult to appreciate the calcification on the MRI. In the MRI images in this patient with the Brenner tumor. Struma Ovarii on ultrasound, solid and cystic appearance may be associated with mature cystic teratoma. May show rounded or oval echogenic nodule, stroma beads. On the MRI, hyperthyroidism in about 5% of patients, plus minus mature cystic teratoma with its characteristic appearance due to fat contents, loculated cystic mass with variable signal characteristic. Some locules may show marked hypointensity at T2 weighted images and intermediate signal at T1 weighted due to thick gelatinous colloid. Strong enhancement of solid component on post-contrast T1 weighted images. Here we see Struma Ovarii sagittal T2 weighted images with multilocular cystic mass. Some cysts are low signal intensity due to thick gelatinous material as we described. And this is an ultrasound patient with multilocular cystic ovarian mass with multiple echogenic rounded intracystic stroma beads, characteristic sonographic feature of Struma Ovarii. Fibromatosis, enlarged ovary with the presence enlarged ovary with a preserved ovarian shape, a preserved ovarian follicles. We have this large mass in 13 years old girl, repeated episode of severe pelvic pain, shows massive enlargement of left ovary with demonstrating increased signal intensity, except for the segmented of very low at the periphery. Note that also the follicles are seen in this patient. And then this T1 weighted images with the same patient, after contrast there is no enhancement is noted on this patient with ovarian fibromatosis with thank you for listening. Hoping to see you soon in another talk.